To tell you a little bit about Migraine and Headache Australia, our mission is really threefold. Our goal is to provide trustworthy and reliable information, and we're doing that through medically reviewed articles that are continuously being added to the website. We fund research into migraine and headache, and we try to do this at least in one research project a year. We've funded 8 projects over the last 11 years. And we advocate and support people living with headache disease. And I'll talk a little bit about some of the things we've done in that space recently. And in fact, here are some of the things that we have done just in general with Migraine Headache Australia. We've been quite busy. Last night, we spoke about our Commit to Care campaign running this month, which is just about taking small steps to help you turn the corner in your own health and well-being. We'll also be talking about one other program each night that we've done to give you just a bit of a taste of what we've been up to over the year if you have just joined the community. And tonight we're going to be talking about the PBS listings. So to speak about the PBS listings, here are some treatments, some migraine preventives, which you'll learn about in more detail tonight from Dr. Stark, that are approved by the TGA, which is the Therapeutic Goods Administration, which approve drugs for medicinal use, and also the status of whether they've been listed on the PBS. And so we have here a few treatments that may or may not be familiar. Botox has been listed since 2014, which is kind of surprising. Just, it feels like it's only been listed recently, and yet it's been there since, for almost, 6 years now. And then more recently, we have the anti-CGRPs. Now, if you're not familiar with the CGRP, it's a fancy name. I will let the expert explain exactly what they are because we're going to learn all about them. But we have 2 of those listed only just this year. And this has been something that's taken a couple of years in the making. We made, the Migraine Headache Australia community made 1,800 submissions from you and from ourselves to the PBS advisory committee, called the PBAC for short. And slowly but gradually, they heard our cause as well as the cause from all different stakeholders across the field to get that approved. And today we have 2 options that are covered that make access to these very important treatments far more affordable and accessible for the greater population. So it's really good news, but it doesn't come easily. It has been a couple of years in the making. Now, to make sure you're in the right place, if you have migraine or headache, if you're a parent or a caregiver or partner of someone, if you just want to connect and with others like yourself or hear questions, or if you're here for the questions and the Q&A, you are in the right place. Now, if you do want to ask a question, this is the place to do so. So you can see here in the bottom right-hand corner, you can probably see chat mode at the moment. If you click on that chat mode icon or text, you can swap over to Q&A mode. And when you do that, our moderator, Anik from Migraine Headache Australia, will get flagged that that's a question that you would like asked at the end of the presentation. So as questions arise, you can ask them, or you can save them up to the end, or do both if you're very keen to make sure your question is answered. We will do our best. There's a couple hundred people that have joined us tonight, so we'll do our best to answer as many questions as we can. So let's talk about who we have tonight, Dr. Richard Stark. He's the Deputy Director of Neurology for Alfred Health in Melbourne. He's the President of the Australian and New Zealand Headache Society. If you don't know what that is, it's basically the medical profession, the peak body for headache and migraine in the country. And he leads that organization. And he's also active at a global level with the World Federation of Neurologists, acting as a Trustee and Treasurer. He's published over 50 articles, and he has a busy practice. And so he's very experienced, and he's also doing research in this space. So I can't think of anyone better to cover this topic than Dr. Stark. So without further ado, let's commence our presentation.
Hello, I'm Richard Stark, and I'm delighted to be able to speak to you today about prevention of migraine and some of the new options that we have for that. These are some of my disclosures. So really what I'm going to be talking about today are preventive treatments. Now, triggers and lifestyle factors and treatments when a migraine occurs are all important, but they're a separate issue, and I won't be talking about those today. Preventive treatments, really, we've had many treatments over the years, and there's a long list of these that are available, but we do have some newer ones that are available, and in particular, the excitement is that we've got some new injectable treatments that have become available in recent years. We'll also talk a little bit about neurostimulation as a treatment option, and some specific measures that we can take for menstrual migraine. So I apologise, I'll be using the word prophylaxis from time to time, but that's really the technical term for preventive treatment. So if I use that term, please understand what it means. Who would we consider using preventive treatment for? Typically, it's for patients who have got maybe 4 migraine days a month or more, but there might be situations where migraines occur even less often than that, but when they occur, they're so disabling that it warrants being on a preventive treatment. And as I said, we now have many, many different options for treatment of migraine. I was fortunate enough many years ago to be involved in a study where we looked at general practice behaviour, patients going to their GPs and seeing how many of them were put on preventive treatment and which preventive treatments were chosen. And the end result was that even patients who were getting very frequent migraines were probably only 1/5 to 1/4 of them being given preventive treatment. So it did seem to be that perhaps treatment options were being underutilised at that time. In addition, when we asked which medications were being used, there were really only 2 that were being used by GPs in any large numbers, and they were pizotifen or Sandamigrane and propranolol, Inderal or Derolan. And it struck us at the time that there were a number of other options that were really being underutilised at that stage. And since then, we really do have a lot more options that are available. So just to mention the options that we have, there are really the traditional first-line treatments, things like propranolol, pizotifen, and amitriptyline. We've got some second-line treatments that have been around for quite a long time as well, and these can be effective for some people. So sodium valproate or Epilim, cycloheptadine, clonidine, verapamil. We've got some oral therapies, so tablets, that have come onto the market more recently, and these are probably still a bit underutilised. One of them is topiramate, Topamax, candesartan or Atacand, and lamotrigine or Lamictal. Many patients will try natural remedies, and these can be helpful, but I guess in my experience are probably not quite as potent as the medications that I've listed above. We've now got these new injectable treatments, and Botox was the first of these, but then the CGRP antibodies, so the ones that are most readily available now are Emgality and Ajovy, and I will spend a bit of time talking about those. Neurostimulation refers to using electrical stimulation of nerves to try to change the pattern of migraine. And I will talk a little bit about menstrual migraine and special techniques that we can use in that situation. So there are some general principles that we need to look at in patients that have migraine and are considering preventive treatment. And one of the things that really strikes me is that many patients are anxious about side effects, particularly from some of the older medications. And indeed, it is true that there are side effects that can be bothersome in certain patients. And I'll go into that. We obviously need to think about individual patients and avoid treatments that would be particularly troublesome for them. One of the other big problems is that patients tend not to persist with treatment. All of the treatments that are given for prophylaxis need to be given on a regular basis. and need to continue on to be effective. And it is certainly true that many patients will not persist on with treatment, particularly if there are side effects developing. So that's one of the things we have to address. Against that, the benefits of many of the treatments tend to be cumulative. That is to say, while there may be some benefit in the first month or so, it's often even better in the second and third month. So there is some benefit in the patient persisting on with treatment. The benefits do tend to be greater when the dose is higher. So we do need to be prepared to push the dose up. But against that, side effects tend to be greater when the dose is higher as well. And so we have a balancing act to deal with. We need to talk about the benefits versus the adverse events. And it really involves having quite a sophisticated discussion with patients. The other thing that really is a big factor in patients who have very frequent migraines is the issue of medication overuse headache. And this refers to a situation where patients are taking acute treatments, painkillers, for example, very frequently because their migraines are frequent. And the problem then is that those medications become less useful, the body becomes used to them, and we can get into a rolling pattern where the withdrawal of a medication, that is to say, when the medication level dips in the system, can be enough to trigger the next headache. That then gets treated with more medication, and you get into this rolling pattern. It's one of the reasons that we really are keen for people in that situation to be on effective preventive treatments. Now, here's a long list, and I don't expect you to read all of it, but really the point I'm making with this list is that there are a lot of different preventive medications which can all be effective in some people. All of them have got their own set of side effects, but usually those side effects are manageable. However, one needs to be careful that you don't give the wrong drug to the wrong person. So, for example, Sandomigrane is one of the commonest drugs that are used for migraine prevention. It can cause drowsiness if it's given at high dose straight away, but most people, where the dose builds up and it's given mainly at night, don't have a problem with that. But one of the big issues is weight gain. So patients who have been struggling with their weight really do find this a difficult drug to use. And I always ask patients, whether they have had difficulties in keeping their weight down. There are some patients that you would really never consider prescribing this medication to for that reason. On the other hand, patients who have not had trouble with their weight may often find it a very effective treatment and a very useful treatment. And people who've not had a past history of weight gain often are able to tolerate it very well. That's just an example. Another one is propranolol, or the beta blockers tend to make asthma worse. So if a patient's never had asthma, that can be a very effective treatment. But if they have had asthma, we would avoid it. One of the problems that I see when patients come to see me is that they say they've been tried on preventive treatments in the past and have not been able to tolerate them. Now, it's really important to pin down the details of what happened. We need to find out what dose they were on, how long they were on a medication. And it is true that some patients are very diligent and read the information about medications and assume that all of the side effects that are listed there are things that they will certainly get. In most cases, side effects occur only in a small proportion of patients. And if that's the case, it means that there are many patients who will be on the medication and won't have trouble with that side effect. So it's important to sort of go through that discussion and explain. It is true, though, that many patients do not persist with medication. So this was from a study that was done in the United States. And what you can see is that within a couple of months, over half of the patients have no longer been taking their medication. And by the time you get out to a year, it's much less than a quarter. So it is true that for standard, long-standing preventive medications, we have a big problem with people being able to persist with them. So I see patients who have said, look, preventive treatment doesn't work for me, it doesn't seem to suit me. So why might patients be saying this? That they may have a general reluctance to being on medication, but of course, they also have a reluctance to have frequent migraines. So it is a matter of talking through that. They may have had unacceptable side effects, and it really is important to think in advance what sort of side effects might be troublesome from an individual patient and try to choose a drug that would be suitable for them, given that background. Poor compliance or not persisting with medication or not taking the medication as intended is a big issue, and it's a hard task for people to take medication every day, particularly if they need to take it twice a day. So if there are medications that can be done on a once daily approach, that's preferable. But of course, it's one of the great advantages that the newer medications, the injected treatments have. They are injected infrequently, Botox every 3 months, the CGRP antibodies every month. And finally, the patient may tell you that the medication just simply didn't work well enough. And we need to look at diaries and see what the information is, whether there really was a complete loss of effectiveness. And of course, the way around that in the long run is to get better drugs, better medications available. I do like to show this graph to patients. It relates to topiramate, which is one of the medications that we use, but similar things occur with all medications. The top line there with the diamonds was in the trial, patients were given placebo. So these were people who improved a bit, even though they were not given active medication. However, all of the active treatments work better than placebo. The ones in squares were at a low dose, 50 milligrams a day. And for some patients, that was sufficient and it worked well. A higher dose of 100 milligrams per day is the triangles, and they worked better still. But of course, a very high dose of 200 milligrams a day, the black circles, work better still. So the higher the dose, the better it works. Why don't we always use the high dose? Well, of course, the higher the dose, the more likely you are to get side effects. So what it really means is that there are some patients who can tolerate that high dose, and it's best for them. There are other patients who would get side effects even with the medium dose, but get a good response from the low dose. So again, we need to just actually listen to what patients are telling us and be sure that each individual is on the best dose for themselves. The other thing that this graph tells us is that there is progressive benefit over time. So if you look maybe at the triangle line, you'll see that patients who have been taking this standard dose of topiramate are improved after a month, but are significantly better after 2 and then after 3 months and so on. So there is progressive benefit over time. And that's the case with many of these medications. Just to mention, candesartan or Atacand was discovered only relatively recently to be effective in migraine, and it's a very useful drug for many people because it is very well tolerated by most people. Lamotrigene's a bit different. It's a medication that really isn't much use for people who get migraine without aura, but people who get the visual aura or other aura symptoms as a prominent part of their migraine, they do very well with lamotrigine. So it's one that we keep in mind for those patients. Okay, moving on to the newer treatments that we have. These really are the botulinum toxins, the Botox, and the CGRP antibodies. All of these medications clearly work well. Botox works in patients with chronic migraine, that is, migraine occurring more than 15 days a month. The CGRP antibodies also work in this group of patients, but they also work in episodic migraine. The CGRP antibody studies included some people with medication overuse headache, and it does seem to be that these medications work well for those patients too. The really good news is that these medications all seem very safe. They seem remarkably free of troublesome side effects. And of course, being injected infrequently, compliance is much less of an issue. if the patient has the treatment, they are then not due for their next dose for at least a month away. These treatments are all intrinsically expensive, but fortunately we do now have PBS approval for Botox and for 2 of the CGRP antibodies. So when we're considering these agents, we need to be very aware of the criteria because that makes the medications much more affordable. So to qualify for these new medications, patients need to have frequent migraine. They need to have headache days more than 15 days a month, and this needs to be recorded by diary. They need to have tried and failed standard preventive treatments before, at least 3 of them. They need to have medication overuse headache addressed. All of these medications are approved on the PBS for people aged 18 years and over. And of course, there are some situations where 17-year-olds, particularly those who have got studies to do, may be desperate for treatment. We have to keep that in mind. The other thing that's particular for Botox is that sometimes patients have heard that it's effective and have gone to see a cosmetic physician or a GP and have been tried with it earlier on. The problem with that is that GPs and cosmetic physicians tend to use quite a low dose of Botox because of its expense, and it may not therefore be an adequate trial. We typically use 155 units of Botox for migraine treatment, and often patients will be given 20 or 30 units by a GP or cosmetic physician. How does Botox work? It gets into nerve terminals and it prevents the release of various chemicals from those nerve terminals. It stops release of acetylcholine, which activates muscle, and that's why it is good for loosening muscle fibers. But in migraine, it probably works by getting into the sensory nerves and reducing release of various chemicals from those pain fibers, including CGRP. So there is some sense in using Botox for treating migraine. When we do use it, we inject typically 31 different sites over the head and neck area. And these sites are designed so that they're actually over the areas where the major sensory nerves are. So it makes sense. We inject areas where we know there are significant sensory nerves. The Botox gets taken up in the nerve, and that's how it's effective. And we know that Botox works well in many of the patients that we treated. There have been good trials that show this. So it really is a very helpful treatment, and it really has changed the way that we manage patients who have got very frequent migraine. It's been around now for a number of years. And we'll see patients who bring in charts like this showing that their headaches have gone from being very frequent and severe to much less frequent and much less severe. What about the CGRP antagonists? These are new medications and have just recently become available through the PBS system. That's Emgality or galcanezumab and fremanezumab or Ajovy. They are approved for chronic migraine only, that is more than 15 headache days a month. People have tried 3 standard preventives, and the government then allows us to use these for a trial period of 3 months. And then to continue beyond that, we have to document that the headaches have been improved. The headache days have been reduced by half. You may have heard of Erenumab or Aimovig. This is a medication that has been approved by the TGA, but is not yet PBS funded. And so that is intrinsically much more expensive and is really, for many people, not a practical option. There is a new medication, Vyepti or eptinezumab, which is given not by subcutaneous injection into the skin, but by infusion intravenously every 3 months. That's recently been approved by the TGA, but it's not PBS funded yet. It may become PBS funded in due course, and that may be an option for some patients as well. So how do these work? CGRP is a peptide, so it's a chemical that's produced in nerve fibres and is released from them. It's certainly important in migraine production. It's found in nerve fibres around the head and neck that we know are sensitised in producing migraine. And it is clear that blocking this chemical is very helpful in dealing with migraine for many patients. Here are some of the places that CGRP is found around the blood vessels and other structures in the head and neck area. So how do these chemicals, these new medications work? So Aimovig is an antibody against the receptor for the CGRP, while Emgality and Ajovy and Vyepti are all antibodies against the CGRP molecule itself. But the end result is the same. It prevents the molecule from connecting with the receptor and activating the sensory nerve fibres. And it is clear that all of these medications work well in chronic migraine. They reduce the number of headache days. There are large numbers of people who get a better than 50% response. And it is true that they don't work for everyone, but they do work for many of the patients that we see and have made a big difference to the way we treat migraine. Let me talk briefly about neuromodulation. So there are various ways that we can stimulate nerves around the head and neck area that can make a difference to the way migraine behaves. It's possible to stimulate the occipital nerve at the back of the head, but that generally requires an implanted electrode. There's a method of stimulating the supraorbital nerves above the eyes with a device, and that can be effective. And there is now a way of stimulating the vagus nerve, which is in the neck here, with a stimulator, and that can be effective as well. It's interesting that years and years ago, in the 1st century, the Emperor Claudius's doctor recommended application of a live electric ray to the site of head pain. So I think that would be a fairly frightening form of treatment, but perhaps it was the precursor to these neurostimulation techniques. So here are pictures of the Kefali device, which stimulates the supraorbital nerves, and the gamma core device, which stimulates the vagus nerve. And both of these can be effective for some people with migraine as a preventive measure. There is evidence that the Kefali device works. It was a bit tricky to prove this because we always like to compare a real treatment with a sham treatment. And of course, patients were able to tell whether they were being stimulated or not. But they managed to devise a trial which enabled that to be done. And it was clear that the Kefali device was helpful for a number of patients in reducing headache days. And looking at real life experience, the way that Kefali was brought onto the market, it was provided on a rental basis for a month or two, and patients could then decide whether they wished to buy it or to return it. And in one trial, about half of the patients chose to buy the device, so they obviously perceived that it was effective for them. What about the gamma core device? Again, we've got evidence that that can be helpful for a number of patients with migraine, and indeed for patients with cluster headache as well, which is another very difficult form of headache to treat. Again, there's a group of patients who do not persist with using this, and presumably they're patients for whom it has been less effective. But there is a subgroup of patients who find it helpful and continue to use it for many months and report benefit from it. And so here's a graph showing those who did choose to continue on for up to 8 months. Up to half of those were getting a 50% response, whereas those who gave it up earlier on were obviously not doing quite so well. So these devices have the attraction that, of course, they're not a drug. They don't carry any of the drug-related side effects. They can be effective, for example, in people during pregnancy, when we're anxious about using other medications. I don't want to spend too long talking about medication overuse headache, but it is an important condition for people who are getting frequent migraine. And one of the concerns is that there are certain medications that we use to treat migraine acutely that seem to be particularly troublesome at causing medication overuse headache. Medications that include opioids, that is to say, morphine or codeine-related compounds, are particularly troublesome in this regard. The triptans, so Imigran, Zomig, Naramig, Maxalt, Relpax, can cause medication overuse headache, but they're not as bad as the codeine-based medications. But simple analgesics and anti-inflammatories seem to be much less of a problem. So for people that are getting very frequent migraines, we need to keep this in mind and generally prefer to use anti-inflammatories with occasional triptans rather than relying on opioids. And this is really a good rule of thumb that we try to reduce triptan use to maybe a couple of days a week maximum. Codeine we really prefer to avoid in patients who are getting frequent migraines, and obviously injected narcotics are a concern. Let me briefly speak about migraine in women and menstrual migraine. There are some women who really don't have too much trouble with migraine except at period time. And for these patients, there is the option of giving some medication just across the time that they are vulnerable. And the options that have been put forward here in a paper from overseas are using naproxen for a period of maybe 7 to 14 days, or estradiol gel to keep the estrogen levels level, or a long-acting triptan. Now, provatriptan was recommended in this paper, but that's not available here in Australia. The longest acting triptan we have here is naratriptan, and we do sometimes use that. You'll see that all of these strategies are typically started a little bit before the period begins. So for that to be effective, it means that the periods have to be regular and predictable. And obviously migraine must be predictable at occurring at that time predominantly. However, there are quite a few women where really period time is the biggest problem by far, and this is an option for us. So take-home messages. Migraine, we know it's under-recognised and under-treated in the community, and the treatment can include things like lifestyle measures, acute treatments and prophylaxis. We've been talking today about prophylaxis or preventive treatment, and there are many, many options, some of them old, some of them new, but I think probably all of them underutilised. We need to be aware of potential side effects and reasons why patients may be reluctant to use treatment, and talk through and have a partnership with patients to get the best treatment for them. There are new and exciting treatments emerging, and they do include repurposing some existing drugs. But of course, the big news is Botox and the CGRP antibodies, which have really revolutionised the treatment of chronic migraine. We do have some promising results from neurostimulation, and we do have some specific approaches to menstrual migraine and medication overuse headache. So there's a lot to talk about in prevention of migraine, and I'd be very pleased to discuss this further now.
All right. Thank you very much, Dr. Stark, for that wonderful presentation. That was a lot to cover. There's lots of questions that have come through. So if you've been holding your hands clasped and ready to ask your question, now's a good time to post it. We'll jump straight into some questions from the community. So to kick off, we've got a question from Beck, who asked, are there any preventive medications that can help people with cluster headache? particularly if the clusters are separated by years?
Okay, so cluster headache, of course, is a different condition from migraine, and it's easy to get the two confused because some patients with migraine get runs of headaches coming one after the other. So that's a run of migraine, but it's not cluster headache. So we do need to be sure what we're talking about. With cluster headaches, typically this really severe headache that involves one eye, comes for an hour or two at a time, clears away, and you may get a run of them lasting for 6 weeks or so. So there are specific preventive treatments for that. They're a little bit different from what we use for migraine. The commonest one, in fact, is one called verapamil, which is a medication originally used for blood pressure, but turns out to be very good in cluster headache. We do occasionally use it for migraine as well, but it works much better for cluster headache, but may need to be in a very high dose. The problem with that is it takes a while to get the dose built up, and patients with cluster headache want relief straight away at such a terrible pain. So we sometimes use, in those patients, an intermediate method, a sort of a bridging treatment to get quick control of the headache. And that can include things like oral prednisolone, or sometimes for a short course, or sometimes injections of corticosteroids into the back of the head, occipital nerve blocks. So there are some specific tricks that we use in treating cluster headache. They're a little bit different from what we use in migraine.
Wendy had a question about the antibodies of CGRPs. Do patients themselves develop antibodies to the CGRP?
So patients don't typically develop antibodies to CGRP, but theoretically you can develop antibodies to the drugs, to the CGRP antibodies themselves. And it's been one of the questions as to, if people are on these and they've been working for a while and they seem to be not working so well, might that be due to the development of antibodies to them? We know that that's theoretically possible, but it seems to be something that actually happens very, very rarely. So in my experience, I don't think I've seen any patients where I'm convinced that there's been antibody development that stopped the way that CGRP antibodies have been working. So I'm, it can happen, and it would be really nice if we had the opportunity to actually measure those antibodies, but that's not a test that's easily available to us. I should say, and I can probably preempt one or two of the other questions, with the CGRP antibodies and with Botox as well, we do sometimes see fluctuations from time to time in how people respond. And we've had Botox around for a lot longer, and it's very common to see people who get a good response, and then one set of injections just doesn't seem to work quite as well. And usually that doesn't mean that it's not working anymore. It just means that for some reason that set of injections didn't work so well. And I guess one of the possible explanations for that is that when we inject the Botox, it doesn't just act. It actually has to be absorbed into the nerve cells. It has to be incorporated into them. It has to then bind to the various things that it blocks. And all of that depends on how the body is working at that time, as well as how the Botox is working. So I did spot a question that was saying, look, I had Botox after my recent Pfizer shot, and it didn't seem to work so well. Could that be a real thing? Well, we don't know for sure, but it's not impossible that with the body being activated and doing things to deal with the immunisation, that maybe the Botox wouldn't have worked quite so well in that particular person at that time. So I think there can be fluctuations in how they work. It doesn't necessarily mean that they're wearing off.
That's really interesting. And we're going to be talking about treatments with COVID and the vaccine and interactions tomorrow night with Dr. Tissa Rujaratne. So if you're interested in that topic, stay tuned and tomorrow night. One of the other questions we had was from Joanna about which treatment may be safe for pregnancy.
Okay, well, it's a very tricky question because if you look at the guidelines that are published with all of these drugs, they recommend that you don't use them in pregnancy. And essentially any new drug that comes out won't be trialled in pregnant women because one doesn't want to take a risk. And so they come onto the market with this proviso that the safety in pregnancy has not been established. So that's always a problem. What happens is that the older drugs get, the longer they've been about, we get more experience of people who have in fact been given them during pregnancy, and we get to know which are probably safer. So the brief answer is there probably are none of them that are declared to be safe in pregnancy, but there are some that we feel a little bit more comfortable about using in pregnancy than others. And generally it's the older ones that have been around compared with others. I must say one of the things that confronts me, I see a lot of people who have got very difficult migraine, chronic migraine, and a lot of people who are being treated with Botox or CGRP antibodies. One of the advantages that Botox has is that it works for 3 months, but the actual chemical is free in the body only for the first few days after injection. It works by getting bound to the nerve terminals, the nerve fibres, and then it has an effect on them. And the actual Botox isn't around for much longer. So in the time when someone's thinking about becoming pregnant, they're trying to become pregnant, but is not pregnant yet, that gives us a problem with some of these medications because you don't, if you're prescribing a tablet, you don't know if someone will be pregnant next week. But with Botox, we can probably inject and be sure that they're not pregnant now, and the way things are going, they're not going to be pregnant for the next week, but maybe they will become pregnant thereafter and it will be safe. So it's a great question, but it's a difficult question.
Gregory Longman had a question about Botox and the anti-CGRP being used together and some work being done overseas in that space, but only one's covered at a time with the PBS. And Anna also expressed interest in this question. Do you think there's likely, that's something that may likely progress in Australia as well?
So look, I have to say that I do have some patients who are on both together, and they've obviously been difficult patients where neither by themselves has been sufficient to produce a sufficient benefit. And certainly there are a number of patients who feel that they do better on the combination than with either alone. And I know that there is work being done overseas looking at this, and there's theoretical reason to believe why they might be good working together. But you're right that at the moment you can't have both funded together on the PBS. So if you're going to do that, it means that you need to self-fund one and have the other on the PBS, which makes it obviously a much more expensive situation. Look, we would love to see all of these treatments available as freely as possible, but my guess is that it's not something that's probably going to progress quickly at government level, having both together.
Priscilla had a question about the success of a treatment and what is the benchmark of success. She said that she's on a treatment at the moment that's reduced her migraine attacks from 1 per week to 2 per month, so fortnightly, with very few side effects. Is that successful in the eyes of a clinician, or should she try another preventive?
So look, I think it varies enormously from person to person and how the migraine is affecting them. So, the easiest thing to do is to count migraine days or headache days. But one of the other things that we do see, and it makes it much more difficult to analyse, is patients may go from having, let's say, 6 or 8 severe migraine days a month to 3 or 4 headache days a month, but much less severe, much easier to manage. They respond much better to simple medications. So when you're counting, it doesn't sound all that great. You're still getting 4 migraines a month, but they're 4 migraines that you can treat, take a tablet, and you're better within an hour and can get on with your day's work. And as opposed to being out of action for all of the day otherwise. So I think I'm going to dodge the question by saying it depends on a number of things. But for many people, going to a couple of months that are easily managed is a good result, and they're happy with that.
We had a question about medication overuse headache or rebound headaches. Can they occur from opiates and triptans? And I know that Samantha Holt was interested in this. Jennifer, Janelle was also asking about Tabental or Tabentabal. And Codeine Cannon was asking about, all relating to medication overuse.
Okay, so essentially all of the medications in the opioid group can potentially cause troublesome medication overuse headache. So that includes codeine, it includes tapentadol, it includes the combinations that have got codeine in them, so Panadine Forte and so on. And we regard these as being medications that are particularly susceptible to producing medication overuse headache. So I really would always be very cautious about suggesting they be used at all for migraine, but certainly no more than a day or two a week max. Triptans undoubtedly can cause medication overuse headache as well. And again, we prefer people not to be taking those more than about 8 to 10 days per month. And it seems to be if it's less than that, this rebound issue doesn't become such of a problem. If it gets above that, it can be a big problem. In my experience, it's actually a little bit easier to get people to stop their triptans and get out of the medication loop than it is with the opiates, which are really very difficult to stop. So I guess what I do is I really tune into how frequent the patient's headaches are and how often they're needing to take medication like this. And if you're getting one bad headache a month, you can sort of take whatever you like because it's not going to give you medication overuse headache, whatever works. But if you're getting 10 headache days a month or 15 headache days a month, you really do have to be a bit cautious, and you probably need to use triptans maybe for the more severe half of those headaches, maybe for 7 or 8 max, and try and manage the other ones with things like anti-inflammatories and so on. Very difficult. Naproxen's a good one. Naproxen doesn't tend to produce medication overuse headache, for example. But I mean, it's easier said than done. If you're getting headaches 15 days a month and you've got a function, what do you do? And so the point is we really do need better preventive treatments, and I think we are starting to be on the way of getting them.
What about for someone like Jilly who takes 4 to 6 tablets of Panadol each day? Can that help prevent migraine, or does that actually contribute to more attacks?
So taking Panadol every day probably can cause medication overuse headache. Panadol's not as potent at doing that as the codeine or the triptans, but it can do it. And the people in Europe have written a lot about using simple analgesics too frequently, contributing to medication overuse headache. So I think the brief answer is yes, it can contribute to medication overuse headache. And it is true that people sometimes think of this as a preventive measure because they feel just a bit not quite right and they don't want to go out and have a headache today. So they sort of nip it in the bud before it starts. But it's really not an ideal preventive technique, and we really ought to be looking at other ways of doing it. Just as something that might be in the future, there's a group of medications called the GPAMs, which are CGRP blockers. They're small molecule blockers. And they have been used initially as treatments acutely for when the headache comes on, you take a tablet in the same way that you might do a triptan. But it seems to be that they actually can be used on a daily basis without running into this rebound problem as well. And so that they might be really the first medication that we've got that we can use both as an acute treatment and as a preventive treatment. And that's, to me, is probably one of the great hopes that we will see with the GPANs. I don't know that they work any better than triptans acutely, but for people who are getting very frequent headaches, they may be a sort of a way out of this concern about medication overuse.
And what's the timeline look for GPANs arriving in Australia? What work's been done to bring them out?
So I know that there are a couple of drug companies that are looking very closely at getting them into Australia at the moment. I can't tell you what their timelines are, but usually, the time from presentation to TGA to getting things through, it's usually at least a couple of years. So, it's not like something I think we're likely to see readily available within the next year or so. Although there may be, once they get the first approved by the TGA, they may become available on things like patient familiarisation programs. We'll be interested to see what happens with that.
So we had another question regarding preventive treatments. Are they effective for chronic daily headache rather than migraine?
Okay, well, chronic daily headache's a term that just means any headache that's occurring more than 15 days a month. And there are various types of chronic daily headache, but in truth, most of them turn out to be migraine. Now, there are a couple of other examples. There's a thing called hemicrania continua, which is always on the one side of the head, which is a bit different. There's a condition called new daily persistent headache, where the headaches start on a particular day. Doctor, my headaches began on the 4th of June 2019. Patient comes in and says that they've had a headache ever since. That may be new daily persistent headache, which is a little bit different from migraine. But the majority of patients with chronic daily headache, in fact, if you look into the history of the headache in enough detail, they turn out to have migraine. And so they may well respond to the things that we've been talking about.
A few people have asked about, and Connie is one of them, about getting used to the treatment dosage or becoming less responsive to a certain dose of a preventive treatment and having side effects and changing side effects or getting used to side effects. Do you see that often in your patients?
So I think with a lot of the conventional treatments, the tablets that we talked about that have been around for a long time, it is very common for patients to report fluctuations in how they respond. So, the graph seems to show that people get better and better over the first few months, but we do sometimes see then people seem to get a flare-up of migraine and the medication doesn't work so well. Whether that's getting used to the medication or whether it is just a natural fluctuation in the way migraine is behaving is always hard to tell. But of course, what we tend to do then is to stop that medication and try something else. And in the bad old days, before we had very many options, what we would quite often do is rotate people through. And so, they would be on Migraine for a while, it would work, and it would stop working. We'd try them on a beta blocker, and that would work for a while, it would stop working. We'd try them on amitriptyline for a while, and that would work, and we'd rotate them around. But of course, these days, we do have these more effective treatments. So for people who have very frequent headaches, we'd be looking at these newer treatments, the injectables.
Jade had a question about what are some of the most common effective preventives for people under 17. He said that, or she said that my son is taking amitriptyline, and she wants to know what options she has for him.
Yeah, so there are layers of answers to that. There have not been enough trials done on young people so that we really don't have the depth of data that we do in adults. Having said that, I think the things like beta blockers, amitriptyline and Migraine are probably the ones that we would look at trying first up. And I have to say that I have used things like Botox and CGRP antibodies, which of course have to be self-funded because they're not covered by the PBS for people under 18, but particularly for 17-year-olds who are fronting up to HSC exams and are having their lives blighted by migraine, and it can make a big difference. So we need to remember that the PBS is not saying you're not allowed to use these medications. It's just simply saying the government won't pay for them.
We had a couple of questions about two people that have vestibular migraine, Anne-Marie and Pravita. Would neuromodulation devices be helpful for vestibular migraine?
Look, they're probably worth a try. The other things, of all the preventive agents that we use, in my experience, the two that are most likely to be helpful for vestibular migraine are probably sandomigraine, that's pizotifen, and lamotrigine, Lamictal. So, and probably most people in that situation may have been tried on sandomigraine because it's something that GPs are very familiar with, but they may not have been tried on lamotrigine because it's not a drug that most GPs would identify with being used for migraine. So I think when I see someone with vestibular migraine that's been having problems, they're the things that spring to mind first, I guess. But obviously you look at the individual and you see what would be appropriate for them.
So our last question, I want to thank you as well for your time and for everyone hanging around for the Q&A. We've had Gregory, Simon, and a couple others. It's a tough question, and it's about CBD oil and medicinal cannabis. Have you seen any research or evidence to suggest that that might be effective as a preventive for migraine?
Yeah, the evidence that we see in the medical literature about it being used for migraine, CBD oil in particular, is that it's not effective. And I have to say my experience has been that people who have obtained CBD oil and used it for their migraine, there is an occasional person who comes back and say they think it's been helpful, but the majority of my patients who have tried it have not been too impressed with it. They've either said that it didn't work at all or it worked a little bit, but it wasn't worth the expense. I think with cannabis, it's a slightly different matter because that has a whole range of other effects, some of which are not very satisfactory. They, it doesn't improve your concentration and so on, but it does tend to relax people, and that may be a factor in it as well. So the brief answer is that I'm yet to be convinced that CBD oil have worked well for many patients. I don't. It's certainly possible that people will come in and say, yes, it's been helpful for me, but I think the majority of patients that have reported back to me with it have said that it's not been a great success.
Well, Dr. Stark, thank you again so much for your time tonight. We really appreciate you sharing your expertise and spending the time after the presentation to answer questions from the audience. Thank you to our audience for your engagement and all the questions. Stay tuned for tomorrow, day 3 of Migraine Headache Awareness Week, where we'll be talking with Dr. Tissa Rujaratne about COVID, vaccines, migraine, headache, and other concerns. But for now, thank you very much for joining us, and we'll see you again tomorrow night. Bye-bye.